Brooks is going to then talk about the esophagus. Here are my disclosures. So the outline is to go through what's new, and there's actually a lot new in the last year in the stomach with regards to gastroparesis and functional dyspepsia. There's a new ACG guideline on gastroparesis. Not to be outdone, the AGA has a clinical practice update on medically refractory gastroparesis. Across the pond, there's a new guideline issued for functional dyspepsia. And then I'm going to give you the latest updates as of this month on the drug pipeline in this space. And we'll review noteworthy DDW abstracts, really with an eye towards things that you can incorporate into your practice, things that are accessible. So gastric emptying is very familiar to us gastroenterologists. We really understand this. Liquids, water empties from the stomach very passively. Indigestible solids require much more work. And if you have gastroparesis, these lines are pushed out to the right. It takes more time for these to empty, these solids in particular. And that's why folks can form bezoars and why you might see big leafy greens, onion peels present on endoscopy for folks who have gastroparesis. So that aspect is familiar to us. What is much, much more complicated is the story with regards to symptoms and where are symptoms originating. So the NIH Gastroparesis Consortium has harmonized how they do gastric emptying studies, since we know there's a lot of variation and like 3% of nuclear medicine labs do things according to the recommended protocol. So this data is important because all these hundreds of patients had the exact same gastric emptying study and filled out the exact same questionnaire with regards to symptom severity. And you can see that that line, that red line, is pretty darn flat, meaning almost no connection between the amount of solid phase retention and how severe your symptoms are. So that's an important point. Another important point is that a lot of the symptoms in gastroparesis record symptoms that overlap with this condition of functional dyspepsia. And often, a Venn diagram is the easiest way to think about this. So the prevalence of functional dyspepsia is 10%, the prevalence of gastroparesis is 1.5 to 3%, but about 30% of patients with functional dyspepsia have delayed gastric emptying, and a vast majority of the patients with gastroparesis meet the symptom-based criteria for functional dyspepsia. So this Venn diagram is sort of illustrating the spectrum that these two diagnoses are on. The most important paper on this topic, though, is still very recent from the NIH Gastroparesis Consortium. And if there's one thing to take away from this talk, it's this paper, okay? So the Gastroparesis Consortium over 12 years developed a prospective database, almost 1,000 patients. And they followed these patients over time. They took their symptoms, they did a gastric emptying study, and about a year later, they asked the symptoms again, and they repeated the gastric emptying study. And based on symptoms, you couldn't separate these two groups. How the clinical course, symptom severity was similar between functional dyspepsia patients and the gastroparetics. But many patients shifted from functional dyspepsia to gastroparesis and vice versa. Almost half, a year later, had their gastric emptying study switch. So they were abnormal, it became normal, or they were normal and went abnormal. Meanwhile, you can see their symptoms didn't track with that at all. So this is this widely, recognized paper that really shows gastric emptying is not a totally fixed result, and that there is movement between groups. So, what else is out there other than gastric emptying? What else matters? So accommodation is another important portion of potential symptom genesis. So most food leaves the stomach within 2 hours. So what happens beforehand? So when a person swallows a meal, the gastric accommodation reflex is triggered, and the fundus relaxes, and that food slides up into the fundus, and gastric pressure does not increase. That's what's supposed to happen. If your fundus is not accommodating appropriately, though, then that material shifts into the antrum, the stomach pressure goes up, and potentially that could explain symptoms such as early satiation and pain. So another way to think about this is, and I got to give credit to Kyle Stoller from Mass General. This is Joey Chestnut, our competitive food eaters. He can wolf down that many hot dogs in a very small amount of time and still, smile after winning the championship. Our patients who have pain within minutes of drinking water, that's not a gastric emptying issue. The only way we can think about that is in terms of a gastric accommodation issue, plus minus other factors as well. But, think about that difference. And so we don't need to do a gastric barostat where a fancy balloon is inflated to measure accommodation. You don't even need to do a nutrient tolerant test. Just that history when you're talking to the patient and finding out what happens when you drink water, or how quickly do your symptoms develop, can sort of clue you in to whether accommodation may be playing a role, and to help guard against having gastric emptying goggles on. So now that we know there's overlap between gastroparesis and functional dyspepsia, allow me to go through the list of FDA-approved medications. It's a frozen tundra out there. We got nothing. So there's no FDA-approved medication. So what have we accomplished by saying you can overlap with this disorder that has no medications? Well, that's not entirely fair. We do have guidelines. And so here's our American guideline from 2017. Test and treat for H. pylori first. Pray they have H. pylori. That's, really the best thing possible. When not, you're supposed to go through a PPI trial, which is a bit of a tough sell these days, given all the things linked to PPI. Then from PPI, you go to a neuromodulator, and then prokinetic, and then psychotherapy. So that's the US model. Across the pond, the British Society for Gastroenterology just released their much fancier diagram. There's not a whole lot different, except I highlighted sort of a couple things. One, after test and treat, talk with the patient about exercise and avoiding dietary triggers. That's not going to work in my clinic. It must be different in Europe. The other thing is they move up prokinetics. So you can go to prokinetics right after test and treat instead of acid suppression, and they hold neuromodulators below. So that's sort of the latest European British thinking on functional dyspepsia. I think everyone's comfortable with H. pylori acid suppression, and to a degree the available prokinetics. Probably this is the most important, in my opinion, clinical trial agent that's been studied for functional dyspepsia. Jan Tock's group did a randomized controlled trial of mirtazapine. That's a tetracyclic antidepressant, and significant improvements over placebo in reducing early satiety, meal tolerance, dyspepsia severity. This is a medicine you start at 7.5 milligrams, you can go as high as 45, or you can sort of cap out at 30. And so that's worth noting. What about for gastroparesis? Well, we've got a lot of new information out there, and I'm going to highlight a few things here on this ACG guideline. One, small particle diet. That's what's advised. No longer low fat, low fiber. Small particle diet. Google that if you don't know what that is, but everyone should be advised to start that. You'll see I've highlighted a lot of the evidence here is low. And then I've put a red box around central neuromodulators are not recommended. Remember that. Here's the rest of the recommendations. A red box also around don't do pyloric Botox injection. The red boxes are still here though on the treatment algorithm. So central neuromodulators are recommended, and consider pyloric Botox there at the bottom of this algorithm. I'm totally innocent. I'm not a co-author on these guidelines, so I'm happy, it's okay for me to point that out to you. It's sort of interesting, but it shows sort of the challenge here in trying to manage these conditions. The AGA clinical practice update on gastroparesis recommends diagnosing the predominant symptom. Is this someone who has nausea, vomiting, or is this sort of an abdominal pain patient? And treat them very differently. And that is sort of consistent with clinical practice, like pyloric interventions. You would think more for vomiting patients, more severe delay. If someone has pain and bloating, you probably don't want to go cutting apart the pylorus. What are the FDA-approved medications to treat gastroparesis? So for diabetic gastroparesis, metoclopramide remains the only FDA-approved medication. It's available as an oral tablet, an orally disintegrating tablet that's not absorbed under the tongue. It still has to go down the esophagus, down the stomach, into the small bowel to be absorbed. And now there's a nasal spray formulation as well. This is the pipeline as of this month in terms of this treatment space. And, we talk about there being a graveyard of treatments for gastroparesis. And the thinking is the bar has been set way too high for all these clinical trials. So, relamorelin, this ghrelin agonist that there was a lot of hope for, its phase 3 was canceled. That drug is done. Tradipitant is a neurocystokinin antagonist, maybe similar to aprepitant, a drug you might have heard about. It did not meet its target in phase 3 trial, but there is still a long-term extension study underway. You can see some dopamine antagonists are in development, a 5-HT4 agonist as well. None of these are close to the finish line, is sort of the short story on this. So let's review some abstracts that I think are relevant. And so the first one I want to highlight is from Michael Camilleri's group at the Mayo Clinic. And this is a randomized placebo-controlled trial of a drug that is FDA approved and available that consists of cannabidiol. So cannabis has like 80 different compounds. One is THC. That's similar to Marinol or dronabinol. That has a lot of psychoactive effects. Cannabidiol is a compound that does not have significant psychoactive side effects. And so in this trial, the dose of 100 milligrams per ml BID was administered over 4 weeks. Symptoms were followed, 29 patients, mostly idiopathic, 29 with idiopathic and another 12 with diabetes. And the patients who received cannabidiol had improvement across all of their gastroparetic symptom indices and were able to tolerate a normal-sized meal. So this is certainly of interest because the drug, exists. It's not a hypothetical drug, and it's from a very reputable group. Another DDW abstract that's very noteworthy is for buspirone. So this is a 5-HT1 receptor agonist that is also available. This is not expensive. It's within reach. Everyone here can prescribe it. And this was a study done by the Gastroparesis Consortium, so multi-center, randomized, placebo-controlled trial. Again, this shortened sort of 4-week horizon. The dosing was 10 milligrams TID, so right before meals. And in particular, this medicine, which is thought to work on gastric accommodation, it helped with the bloating and fullness symptom severity, and it was very well tolerated. So, for your consideration in terms of those bloating patients where, we know that those can be sort of challenging situations, and you want to know what are some options, what's the latest. Now, here's an interesting data regarding GPOEM. A lot of us in Motility were pretty skeptical of GPOEM when it came out, and there's been encouraging data. There's been sham-controlled data out of Jan Tak's group that showed, okay, it seems to be helpful, especially for patients who are vomiting in particular. Well, the interventional endoscopists at Indiana U were one of the first groups to really jump all over GPOEM, and so now they're reporting their 48-month follow-up data. And so the taller the bar graph, the worse a patient is doing. So that blue bar is at baseline before the GPOEM, and you can see consistently across all the different symptoms of gastroparesis at that 1-month follow-up, there's like reduction by half in all of the symptoms. But you can see at each subsequent follow-up, those symptoms are starting to creep up. And so I think cleverly these investigators reported, listen, the symptoms are worsening over time, but we're still much better than where we started. So obviously, I would say we need even more follow-up to see how things play out over time. There was one abstract in this domain which was selected for an oral plenary, and so I wanted to go through that with you. And this was on the topic of nasal versus oral metoclopramide. So probably no one here has prescribed the nasal metoclopramide. It was FDA approved in the middle of COVID. No one I talked to has heard of this drug or used it. So this was the first study to look at, since it was authorized, how did patients fare using it compared to oral metoclopramide patients. And so this is a retrospective claims-based type analysis using a methodology called propensity matching, where you make sure the patients who had the nasal metoclopramide were exactly as sick as the patients receiving the oral metoclopramide, the same age, the same gender, the same type of insurance. And then you looked at the 6 months following that to see how much healthcare resource utilization did they have. And so you start from like 3 million oral metoclopramide and you boil that down to the 257 patients that match the nasal metoclopramide group. And what you can see is in those 6 months, the nasal metoclopramide patients had fewer physician office visits, fewer hospitalizations, fewer ED visits. And that's very significant because we don't have a lot of innovation in this space, but nasal metoclopramide led to these substantial reductions in healthcare resource utilization. My time is up. Thank you so much.